We have enough of a quorum with Dr. Magner also here. So let's begin. We are glad to have Dr. Kristin Clemens from London, who will be talking to us about bone health in advanced kidney disease. Dr. Clemens is a general endocrinologist who practices at the St. Joseph's Hospital in London. She's also the medical director of the Osteoporosis and Metabolic Bone Disease program at the St. Joseph's Healthcare in London. Apart from that, she's also an assistant professor at the School of Epidemiology and Biostats at Western, and an adjunct ISIS scientist. So welcome, Kristin. Go ahead.
Thank you so much for the introduction, and thanks for joining, everyone. It's such a privilege to be able to present to you today. So I listed my disclosures here, so no major conflicts of interest with any of the pharma companies. My last disclosure is that, as we were chatting about earlier, there's very little evidence, unfortunately, from large randomized controlled trials in this space. So much of what I'm going to be presenting you today is based on smaller RCTs, observational studies, and a little bit of clinical expertise. So my objectives are pretty broad. I'd like to just review with you why patients with CKD fracture and help you to understand which of your patients are at highest risk. I'll provide our approach to fracture prevention in CKD, and we'll have a special focus on the dialysis population. I'll go through some of the optimal targets for PTH and perspective about calcium for bone health. And then we'll talk a little bit about the utility of a 25-hydroxy vitamin D. I'll try to give you a little bit of insight as to when a bone density might be helpful for your patients, and then who we think could benefit or could be treated with osteoporosis therapy, when that treatment can be initiated, and we'll review some of the general benefits and risks of some of the bigger classes of medications. And then we'll highlight just a few of the future clinical trials and studies that are coming up the pipeline in this theme. So as an epidemiologist, I have to start with some statistics, and many of you will be quite aware of this. But in patients with kidney disease, fracture is a major issue. So we know that your folks have a 10 to 100-fold higher risk of fracture than age-and-sex-matched individuals without kidney disease. We know that those on dialysis tend to fracture about 10 years earlier than those without kidney disease. And following a fracture, patients face greater lengths of hospital stay. And there's also an increased risk of post-fracture mortality. So the statistics are obviously quite all over the place, but it seems to be about 17 to 70% increased risk of fracture compared to those without kidney disease. So why is it that your patients fracture? And of course, this is very multifactorial. So CKD MBD is something you're going to understand much better than I, but that is a risk factor for fracture, and we'll go through some of that evidence. Your patients can be of older age and have many functional changes associated with their advanced kidney disease, so falls and frailty, sarcopenia. Your patients also live with multiple comorbidities, including diabetes type 1 and 2, type 1 in particular being a risk factor for fracture. And then there's also the risk of osteoporosis, just run-of-the-mill osteoporosis, which we'll talk about a little bit later, but tends to happen in postmenopausal groups or older men. And so we'll really focus on those top two panels because the other two are really talks in and of themselves. But CKD MBD, I'm sure all of the staff and fellows know, but in case there's any trainees in the audience, kidney disease, of course, leads to changes in your PTH and calcium, FGF23, phosphate, and vitamin D. And in addition to risk of vascular calcification, parathyroid gland hyperplasia, we can see bone disease with CKD MBD. And these bone diseases have been linked with fracture risk in some studies. And then there's osteoporosis, and osteoporosis, the most common reason why we have this condition is because there's an imbalance in the amount of bone that is formed and the amount of bone that is resorbed, such that there's a higher rate of bone resorption. And when that happens, this is increased bone remodeling, we see structural deterioration in the bones. You can see this right panel in a woman with osteoporosis. And obviously, when these trabeculi are thin and we lose connectivity and we have this porosity, this bone is going to be susceptible to fragility and to fracture. So that's osteoporosis in its simplest terms. So I'm going to give you some cases, and I don't know if there's a chat feature available in Teams, but you can always just kind of think of this in your own mind. I'm going to give you some cases of patients that you may see in your own practices, and I want you to think about who you think is at highest risk of fracture. And there's not going to be anything about fracs, there's not going to be anything about bone density. It's all kind of clinical. And then we'll kind of go through some of the evidence behind who in fact could be at highest risk. So case 1 is a 65-year-old lady. She has stage 3 CKD, and she's highly functional and lives independently. She has no prior fracture, and she has hypertension and dyslipidemia, and is on perindopril and rosuvastatin. And she's got some basic blood work, which shows a corrected calcium of 2.2. She's got a PTH slightly elevated in our lab of 7.1, and she has a phosphate of 1.0. Then we have case 2. So this is a 70-year-old who was seen in our clinic. So he lives independently. He has type 2 diabetes, and he's got coronary disease. And unfortunately, he fell when he was walking on uneven pavement, and he had a hip fracture about a year ago. And you can see some of his biochemical indices here. Again, phosphate is in good control, and his calcium carbonate. PTH is 3.5. A 25D has been done and is 75, and he's had a bone-specific alkaline phosphatase of 10. And on screening, he has multiple vertebral fractures, of which he wasn't aware of. And then our last case is a 64-year-old lady. She has stage 4 CKD. She lives with her husband, a little bit more frail than our prior case. She's also fairly free of comorbidities apart from her kidney disease, and is on some ramipril and hydrochlorothiazide and canagliflozin. She does have a history of fragility fracture of the wrist at the age of 65, and she had been treated with about 5 years of bisphosphonate. And her biochemical indices are quite good as well. So little bit of hyperparathyroidism and phosphate and calcium, as you can see there. Perhaps just kind of think through who you think is at highest risk, and then we'll come back to this. So the risk factors for fracture in advanced kidney disease are multifold. So this is an epidemiologic analysis conducted by Kyla Naylor at ICS Western. And it was really simple but nice study showing that, first of all, women have a much higher risk of fracture than men, and that's in patients without kidney disease as well. You can see that those of older age also have a much higher risk of fracture, and this was the 3-year cumulative incidence of fracture. And we see this nice kind of graded increase in fracture risk as we move across the CKD categories, and this was as defined by EGFR, of course, with the highest risk in those with end-stage disease or using chronic dialysis. We also have some interesting data. Now, unfortunately, I don't have any data specific to kidney disease, but this is data from Dr. Dachi's group, and this also used population health data. And this was a large cohort study, again, of Ontarians who'd had a fracture, and this was any type of fracture. And then they followed patients forward for a second fracture at any site. And what they did find was that the majority of these fractures occurred much within a 2-year period. And so this is kind of coined a newer term called imminent fracture risk, where we know that those patients, particularly those with a fracture within 2 years are at much higher risk or at high risk of fracture in the near future. And so, although our Canadian guidelines have not been updated in many years, the Endocrine Society has a guideline published in 2020, which suggests really urgent initiation or consideration of pharmacotherapy in these adults who have sustained a fragility fracture at any osteoporotic site. And so that's something that you can certainly use just at the bedside in your patients. And then finally, your patients who have functional impairment and many comorbidities are going to be at risk at fracture. And again, we mentioned the risk of diabetes, hyperparathyroidism, of course. Many of your patients due to chronic illness are probably not having menstrual periods, and so that lack of estrogen certainly can place them at risk. And then, of course, chronic malnutrition and chronic liver disease. So if we come back just to those 3 cases, you probably know that case 2 is the patient that's at highest risk. And for a few reasons, he's of older age, he has type 2 diabetes, he's had a hip fracture in the last couple of years. He's also had multiple vertebral fractures that were detected. So automatically, by our own guidelines, this man is at high risk due to these factors alone. So really no point in doing a bone density on this gentleman. It's really not going to change your management. So what's our approach to fracture prevention? What do we do for this man? And again, we think about this in a multi-lens. I'll admit to you that a lot of this stuff we probably don't do well in our own osteoporosis clinics, but comorbidities and things are things that we're thinking about in our own endocrine clinics as well as family physicians' practices. And so again, I'm going to focus on these 2 bubbles here because I think this is probably where most of our comfort and maybe a little bit more uncertainty is. So we'll talk about CKD-MBD, and of course, as you know well, CKD-MBD is associated with bone disease. So adynamic bone disease, for those of you who may not be aware in the audience, this is low bone turnover disease, typically captured in research using a bone biopsy, but clinically with a lower PTH, and I'll go back to some of that biochemical data. We have osteitis fibrosa cystica, so this is severe hyperparathyroid related bone disease. So what you can see if you look microscopically at that bone is there's a large number of resorption cavities, and you get the osteoclasts or the bone remodeling cells increasing in number and lots of porosity. You have mixed disease, which is quite difficult to sort out. I don't know if we ever can really do this biochemically. And then we have osteomalacia, and all osteomalacia means is that we just can't mineralize the bone, so the bone is soft. And so classically this is, you think of children with rickets where they have the bowing of the legs. Osteomalacia in adults, we obviously don't have as many physical features, but we can see this biochemically and can be due to very low calcium, low 25-hydroxy vitamin D. And so why do we optimize this? And I know from your perspective, there's some evidence suggesting that trying to optimize the PTH may be associated with mortality benefit. And you know that U-shaped curve where the sweet spot seems to be between about 2 and 9 times the upper limit of normal. Yeah, and I know that's controversial, but it's certainly out in the literature. But from a bone health perspective, why we optimize is because some studies have suggested to us that a lower PTH may be associated with fracture. And the most studies that we have for this are in the hemodialysis population. So as you know, we're gonna show you that we've got these studies are small and they're observational, and there's likely going to be some confounding here. But here is an example of a retrospective cohort study. There was about 1,200 patients. They were receiving chronic dialysis, and they were followed for about 4,000 patient years for hip fracture. And what this graphic shows you is that those with a suppressed PTH, so this is a PTH In our lab, it's about a 6.8 or so picomoles per liter. I'm assuming you're probably similar in Ottawa. But you can see that these patients appear to be at a higher risk of fracture, so they had a lower fracture-free survival than those with higher levels of PTH. So that's some of the data that we have in terms of adynamic bone disease. Unfortunately, we do lack studies where we're actually bone biopsying and saying 100% certain that these patients do have adynamic bone disease. But in the absence of that, this is some of the data that we've got to run with. So then on the flip side, so why do we not want people with a PTH of 300 picomoles per liter? And that's because, of course, it's linked with high bone turnover. So we can see Brown's tumors, and we've seen lots of these in our own practice with these patients. And there appears to be some benefit of correction. So it's a little bit of indirect evidence that high PTH has adverse effects. And so in some of our studies and your studies, we've seen that activated vitamin D, so calcitriol, alpha-calcidol, can reduce serum PTH levels, then perhaps improve BMD, and in some studies, reduce fracture risk. And then there are some studies suggesting bone density and perhaps fracture benefit of your calcimimetics in those with severe hyperparathyroidism. So that's some of the evidence that we're again hanging our hat on about why high PTH is not so great for the bone. So while bone biopsy is gold standard for us to really understand what's going on with the bone, as we were chatting about earlier, I don't think many of our centers have access. I know that Hamilton does for research purposes, but we certainly don't. And it doesn't seem to be the technical part of the bone biopsy. It seems to be more the ability of having a pathologist that knows how to read these samples well. So in the absence of that, what we tend to do is we tend to use our biochemical evidence. And there's been a couple of studies, mostly in the dialysis population, which have tried to correlate the PTH with adynamic bone disease using bone biopsies. And what has been suggested is that our PTH less than about 16, for argument's sake, particularly if it's less than 10, really have quite a high positive predictive value for adynamic bone disease. And on the flip side, if we look at a PTH greater than 47 or so, it's definitely not too high, that these patients have quite a high positive predictive value for high bone turnover. When we have patients come through our clinic, we like to try to supplement that PTH with bone-specific alkaline phosphatase, so the fractionated part of the alkaline phosphatase. And that's just because, as you know, the PTH moves around quite a bit, and the bone-specific alkaline phosphatase has a longer half-life and less day-to-day fluctuation. And so what these studies have suggested is basically that a bone-specific alkaline phosphatase at the lower end of normal is quite sensitive and specific for adynamic bone disease. And then if we go on the higher end of the normal range or beyond normal, this tends to exclude adynamic bone disease. And it seems as though when you add that bone-specific alkaline phosphatase to a higher PTH, that having those two factors together work a little bit better in terms of its diagnostics. So what we do, and we've come up with a little bit of a protocol around these patients, is that we tend to, particularly in dialysis, we like to find a PTH between about 2 and 9 times upper limit. And again, it's what we have to hang our hat on. It's not the best, but so far this has worked pretty nicely for us in terms of trying to optimize the bone disease. Maybe I'll stop there to see if anyone has any questions about these first parts that I presented in, and if not, I'm happy to take some time at the end of the presentation.
That's awesome so far. Does anyone have any questions? Please raise your hand or unmute yourself.
How useful is a regular alk phos, assuming you do a GGT, to make sure it's not liver?
Yeah, that's a great question. We're struggling with that quite a bit. There's not a lot of data about the total alk phos. From what I've dug up, it seems as though, assuming the patient has no liver disease, The sweet spot based on observational studies might be somewhere between about an 80 and a 120. Again, without the bone biopsy, it's really hard, but that's what we're trying to target if we can't get the bone-specific alkaline phosphatase. So anything above 80, I feel a little bit better that we're not dealing with a dynamic bone disease.
And if I can ask, how expensive is it? Like, does the lab give you any headache for getting a bunch of
Yes.
BPs? And how often do you measure? Do you measure it in everyone once in a while, or only patient?
Yeah, that actually has just come up recently. So our lab biochemist actually just reached out and said, why are you ordering all of these bone-specific alkaline phosphatases? So they are expensive. We only do it in our center in patients where we're considering anti-resorptive therapy in truth. So we just want to make sure that if we're going to start denosumab, that we're not dealing with a dynamic bone disease. We are having a lot more patients with kidney disease come through our doors, so the numbers are certainly going up, but we're not doing it on everybody. Great, we'll move ahead and again, come back to some questions at the end. So calcium, I know these are your treatment goals from KDIGO, is that you really want to avoid hypercalcemia. I won't talk about this too much, but when it comes to treatment, we very much want to try to avoid hypocalcemia for reasons that you probably know already. And so we'll come back to that. But again, when it comes to CKD-MBD, we don't care as much about hypercalcemia. I know you do. We really care about trying to keep that calcium above the normal range. Okay, and we'll talk about 25 hydroxyvitamin D. I expect that there'll be some questions about this later, because I know there's quite a bit of controversy about whether to check this, to replace this. What do we do? So again, if there's any trainees in the audience, as you know, we get regular old vitamin D, D2 from the skin. We get vitamin D3 from the diet. And then our liver comes in and activates to 25 hydroxyvitamin D. And of course, it's the job of the kidney to activate to 125 hydroxyvitamin D. And as you know, your patients can have a lower 1-alpha hydroxylase activity. And so there is an issue with converting 25D to 125D. So the difficulty is that in addition to your patients having low 125, they also have very low 25 stores, and 25 hydroxyvitamin D is the main store of vitamin D in our body. And the reason is, again, manifold, but a lot has to do with adiposity, low physical activity. For some reason or another, peritoneal dialysis seems to be linked with 25D. There's some issues with the vitamin D receptor. You also have impaired tubular reabsorption of vitamin D. There's impaired skin synthesis of vitamin D. And then through some of the metabolic enzymes, you can have an issue with vitamin D metabolism as well. And so it is a real risk in your patient group. And so our practice, whether rightly or wrongly, is in our patients who are seeing for bone disease, we do replace the 25D. And the reason why is because in our minds, yes, your patients have impaired 1-alpha hydroxylase activity, but it may not be all or nothing. So it may not be an absolute zero. So there still may be some folks that have got some activity there. And so if you do replace their stores, that could land them with a little bit better 125 and maybe a bit better PTH control. So we kind of think of it as a bit of a fuel for renal and cellular 125. Again, this is controversial, and where one study says one thing, the other says something different. But we have seen studies that suggest that D3 could improve hyperparathyroidism in some studies. I have seen that in some of my patients in clinical practice, for what it's worth. And when they have been able to do some bone biopsy studies, and again, small samples, mineralization and bone turnover defects can be observed in those with a 25 hydroxyvitamin D less than 50. So I like to have at least 50, especially in people that are at higher risk of fracture, who I'm going to be considering treatment. So to me, I don't know if that means that you need to be screening all your patients, but that perhaps in a devoted population, it may have a role, and look forward to the discussion later, because I know that this is something, a bit of a topic for you all as well. And so my thought on this is that, yes, we have a lack of high quality of evidence for vitamin D. It is inexpensive, and when we talk about osteoporosis drugs, it is an important backbone, and that is because all of our osteoporosis trials of drugs, all of them give calcium, all of them give vitamin D. So it actually is quite difficult to dissociate the effects of both from the drug itself. So I kind of do a bit of a package treatment, for better or for worse. I think at the end of the day, you do need to have an individualized approach. I recognize that with your patients who are already hypercalcemic and hyperphosphatemic, you're not going to be crazy about putting them on vitamin D, and I think that absolutely makes sense. But in some people, you know, there may be some benefit, and so you could certainly think about it. So that brings us to the end of kind of CKD MBD, and so to go back to this case. You can see that this man's PTH is a little on the low side for my liking, and probably yours too. His bone-specific alkaline phosphatase is also on the low side. This man is taking calcium carbonate with meals, so perhaps there's some opportunity to change that. Perhaps there's some opportunity to come down on the vitamin D, and hopefully keep his 25D up in a good range, and perhaps that'll get the PTH moving a little bit. And I know that this is extremely difficult to do, and sometimes it's a tough battle to get people out of this state. So what we'll do, looking at the time, is we'll go on to talk a little bit about this green bubble here, osteoporosis by bone density. Okay, so bone density is a hot topic. So what is it really? So bone density is measured by DEXA, so dual energy X-ray, absorptiometry, and the principle is pretty simple. It's like an X-ray, so that bone will absorb radiation in proportion to its bone mineral content. So for all intents and purposes, it's basically just calcium in your patient's bone. So that calcium in grams is divided by their measured area, and then you get this grams per centimeter squared. And then you'll see on your reports, you'll get T or Z scores depending on how old your patient is. And all that lets us do is just compare this number to another patient so that we can try to put that patient's results in perspective. Now, the reason why we like to do DEXA in our kind of simpler patients with osteoporosis is because we know that bone density is a valid predictor of fracture risk, and I'll call that in the general population. It's very reproducible with a small amount of variation. So the measurement error is about 5% between scans at the same site. It's really quick. It takes less than 5 minutes, and it's got a very low amount of radiation that's admitted. But as you know, it's only part of the story. So all we get is this picture of bone mass. And so if we think about those earlier, diagrams I just showed you with that high bone turnover and those really kind of thin trabeculi, bone density cannot necessarily capture those things. And it certainly can't capture how strong the bone is. And with your patients, if you had that case 3 put through the DEXA scan, who's probably got some adynamic bone disease, the bone density is not going to tell you that he's got osteoporosis and adynamic bone disease. It's just going to likely say that, the bone density is slightly low, and so you can't do any differentiation. And with the kidney disease population, probably for some of the reasons that we talked about, it inconsistently predicts fracture risk. And the reason for that is because, again, your patients are just so complex. So yes, they can have maybe low calcium in their bones, but they also have lots of other risk factors for fracture that are independent of that bone picture. So again, they're falling, they may have reduced activity, they may have low body weight or steroid use. Interestingly too, the DEXA, where we classically take the picture of the spine and the hip, doesn't detect well cortical bone loss. So cortical bone loss, the prime example is the bone density at the wrist. This is actually where your patients lose a lot of their bone, and that's because secondary hyperparathyroidism tends to preferentially affect that bone. And so we can't see that if we just do the spine and hip. And so some have questioned whether we should be doing radius scans on these patients. We don't tend to do. It's something to think about, but that's another reason why you may not see anything too exciting on the DEXA scans. And then, of course, pretty much everybody has arthritis or osteosclerosis, and so you'll see the spine is often way better than the hip, and so that's really overestimating what that disease is. And so the KDIGO clinical practice guidelines, as you know, the 2017 update suggests that in those who have more advanced kidney disease and risk factors, you can test the bone density if your results will impact treatment decisions. I always have a hard time with that. It's always hard to know, what does that actually mean? But I'll tell you what we tend to do. And first to say, I think pretty much everybody has a bone density when they get to us. So where I'm speaking from are the patients where I don't have a bone density, and where I think it might be helpful, so perhaps maybe helpful in your patients, is probably not in case 2 where he had multiple fractures already, but maybe it is helpful in case 3. So this woman who's had a remote fragility fracture, she's got pretty good CKD, MBD, everything's looking like it's in target. And you don't really know if you need to go the next step with her. It might be helpful if you have a bone density, because maybe if you see that, her bone density is not great at that hip, that may push you to say, oh, you know what, maybe she's someone that we need to think about doing a more of a risk assessment on, and maybe thinking about therapy. So those are the cases kind of where I'm on the fence, and probably also where I think that treatment might outweigh benefit. So if you have a patient who is sick, and you don't want to do anything to jeopardize them with any anti-resorptive, bone density is probably not going to help you, because it's probably not going to change your mind to send them to our clinic or to consider treatment, because that score is not going to change what you do, especially if they have a limited life expectancy. So the other reason why bone density can be helpful, and I'm not sure about capabilities in Ottawa, but there is a software, it's called Trabecular Bone Score, that actually can be assessed alongside bone density. And it's actually, I don't think it's terribly expensive. We're getting it in a couple of months. We haven't had it to date. But it's a bit of a surrogate of the microarchitecture of the spine. And so what you can see is just pictures of what this looks like. So this is good microarchitecture on the top panel, and this is poor microarchitecture. It doesn't project terribly well, but you can see kind of more squiggly lines here on the bone density. And so this will kind of also be scored out for the patient. And it's nice because it's a little bit more associated with bone strength. And again, Kyla Naylor with the chemos data did a little study where she looked at the utility of trabecular bone score in patients. They were ages 40 years or older. There was a small proportion with kidney disease, and what she found was that trabecular bone score did help to predict fertility fractures in those with reduced kidney function and normal kidney function. And this was really independent of the fracs. So if we can get our hands on it, it is certainly helpful, and we'll probably be using it much more in our kidney patients in the next little bit. The other thing you can do with bone density that can be helpful, especially if your patients are tired of going for multiple diagnostic tests, is you can actually get your technologist to do a lateral vertebral assessment. So here's a picture of a lateral vertebral assessment on DEXA, and you can see this wedging of the vertebrae here. So that patient is likely had a vertebral compression fracture. If you see that, they don't remember anything about it, or they do, and it was a really low trauma fracture. This patient's high risk, and so we do need to think about treating. You can see how that kind of correlates on the lateral plane X-ray, and so those are some additional features again in the DEXA scan that might make you want to do it in some of your patients. So what about fracs? So fracs, as you know, was developed by the World Health Organization, and basically uses a combination of kind of demographics, body mass index, as well as secondary risk factors. Interestingly, CKD is still not on here. to try to capture patients' risk of fracture. And there is some studies, including some Canadian studies by Navdeep Tangri not too long ago, showing that the fracs can be helpful in assessing risk of fracture. This was a study that was published using some data from Toronto as well as the United States. It was a smaller one, but they had a nice low EGFR there, and they found that fracs predicted fragility fracture with an AUC that was at a fair level, so it's not perfect. But interestingly, it seemed to do that particularly with the fractures in general, as well as the prevalent clinical non-spine fractures. It seemed to perform similarly with or without BMD. So oftentimes, if I've got a patient who's like in too much pain, for example, to have a BMD, sometimes I'll just do it without. So it doesn't make a huge amount of difference, at least it appears, if we don't include the BMD in the fracs. And this has been validated in those patients who do not have kidney disease as well. And then Dr. Tangri had a much larger cohort using Manitoba data and showed a similar finding. And interestingly, a relationship between fracs and fracture that seemed to be stronger in patients with kidney disease than without kidney disease. In the hemodialysis population, there's been slightly more recent evidence from a European group, which had 718 patients on hemo who had risk factors for fracture. They followed them for 2 years for hip fracture, and they found that fracs performed decently well. And they found that fracs was actually the strongest independent risk factor for major bone fracture. This study, they did have access to the bone density. And you may have also seen, and this is probably due to lots of other factors as well, but there's been some newer studies suggesting that maybe fracs may help with understanding risk of mortality and maybe risk of cardiovascular events. And I suspect this is because the patients who have a high fracs are going to have lots of other comorbidities and things, but it's just some interesting study that I had come across more recently. So we'll finish this kind of workup section with the European guidelines who've kind of moved a little bit beyond what some of the KDIGO guidelines have noted about bone density and fracs. And essentially what they're suggesting is that if you've got patients who are postmenopausal or of older age, particularly those patients who've got some other risk factors for fracture, that you can do a DEXA. They're saying DEXA is okay to do, and you could do a fracs, and you can do the vertebral fracture assessment if you have that. And they've even provided you some intervention thresholds. Now, I don't know if this is based on strong evidence, but their suggestions is that we may want to move towards really treating patients who have a high fracs, maybe even those patients who have a low T-score. And I think it's important, if we have the low T-score, that occurs in people who've already got their CKD MVD managed. I'm not sure that this makes sense if we've got someone who's got severe hyperpara, because as you know, they're probably going to have a low T-score. So maybe if everything's optimized and their BMD is still low, I might agree with certainly thinking about treatment there. And then of course, those people who have had fractures, those are the ones you need to pay attention to. And what we'll do is we're going to move to pharmacotherapy next. So we'll get into this latter half of the panel. So in terms of pharmacotherapy, we'll move through this pretty quickly. It looks like we've still got a little bit of time, but what we do is, of course, in these people who are of higher risk, we go back, we see if there's anything else we can do to optimize CKD, MDD. This is often in concerted effort with you. In our practice, we actually don't do much of this at all. We have close communications with our nephrologists, and our nephrologists are the ones doing the calcitriol, and I'm asking them if it's okay to bump calcium or lower vitamin D, that type of thing. We think about all this lifestyle stuff. This is really important. Fall prevention, physical activity. I think you're doing this all pretty well in your advanced kidney clinics. And then in the right patient, we think about pharmacological treatment. And again, these are the patients where we think the potential risks of our treatments are going to be lower than the benefits. We do have to be careful about this. So this slide's a little bit outdated, but this kind of gives you the studies of drugs that we have that are available in patients with kidney disease, and I would say perhaps a little bit more efficacious than others. So the bisphosphonates, as you know, it seems as though we're really kind of sticking with prescribing them to those with an EGFR and over, although I'll show you a little bit of data from the dialysis population. We don't have a baloparatide in Canada, so I'm going to bypass this. We do have teriparatide or Forteo, so this is a once daily subcutaneous PTH analog. So we can use this in patients with a higher EGFR. I'm going to show you some data about its potential utility in adynamic bone disease. Denosumab, I think everybody knows about, and we'll talk about this. And romosozumab is our newest medication for osteoporosis or Evenity that's been on the market for a couple of years. I'll show you a little bit of data about this and tell you a bit more, but we've really got very few studies in the CKD, particularly the advanced CKD population. So bisphosphonates, most of our data will come from post hoc analyses of small studies. This was studies from Japan, where in phase 3 trials, patients with kidney disease with an EGFR down to 30 received risedronate versus placebo. And all the takeaway here is that the bone density improvement does seem to be about on par with those regardless of their EGFR stage. So that's, we think they likely work as well in patients with normal kidney disease. And that's kind of some of the data that we have. Again, not as much in terms of fracture data, but a little bit nonetheless. I recognize that this data is a slightly controversial, and again was a post hoc analyses. But what the authors found in the Freedom trial, when they kind of sliced and diced patients by creatinine clearance, was that the incidence of fracture at 36 months seemed to be similarly protective in the kidney group who received denosumab versus placebo. There were no patients on dialysis included, and only a handful with an EGFR that was less than 30. But this is what we've got for denosumab. So not great, but it is there. There's a handful of studies more recently looking at denosumab in hemodialysis. This is again a Japanese group that studied 46 patients on hemodialysis randomized to alendronate versus denosumab. Their patients had a PTH between about 6 to about 24, if I estimate that, with a corrected calcium above 2.15. So a little bit on the lower end. And then they received denosumab or alendronate, and then they received calcitriol and calcium for prophylaxis. And what they found, so they did not, and were not powered for fracture, but they did find an improvement in lumbar spine. And femoral neck. Distal radius wasn't that exciting, but that there really was some benefit with both therapies. And the other thing to show you was that they recorded changes in calcium, and there wasn't too much excitement in terms of significant calcium drops. So you can see that the change in calcium when they tracked it post denosumab was about 0.1 to 0.2 with fairly aggressive prophylaxis. And so that can be reassuring to us in a clinical trial setting. From a real world setting, however, we have to be careful because, as you know, I'm sure everyone's seen cases of denosumab gone wrong. This is unpublished data from Dr. Cowan and I, again, looking at new users of denosumab, and we took a look by EGFR. We had very few, unfortunately, treated with more advanced kidney disease. But a few things to point out here is that the risk of hypocalcemia was quite small in patients where calcium was actually checked, so you have to take it with a grain of salt. We do see an increased risk. This was at 180 days as EGFR worsens. We did find about a quarter had hypocalcemia. This was mild, defined as mild hypocalcemia, so calcium less than 2.0. But again, not all captured. And we're doing a bit of a risk factor analysis specifically in this population. And the general population, again, we've got limited numbers, but it seems older age, and those who are starting with a lower calcium level are at risk, which is the reason for why we do like to have our calcium on the higher end, you know, in the normal range before we consider treatment. And so prophylaxis and monitoring is important. We have just completed a quality improvement study just locally because of differences in practice. And so what we do is we optimize CKD-MBD. We use a combination of calcium and calcitriol supplementation plus or minus calcium IV therapy. Sorry, calcium dialysate therapy, and then very close collaboration with our osteoporosis and nephrology clinics. And we've had nice success so far in our sample of reducing hypocalcemia. We also started out with about 33% of our small sample had hypocalcemia. But I think this is making us feel a little bit better about doing this in a controlled setting, though the risk is absolutely still there, and we don't have an optimal approach yet in large clinical trials. So I'm wondering for timing, do you want me to jump ahead, or I've got a little bit about our trial, a few more slides to go. I don't want to cut off too much time for questions.
Yeah, maybe talk about the trial and then we can have questions.
Sure. Okay.
And we can come back to this if need be.
Yeah, we can go back. I just had a little bit more about some of the other agents. But there's not a ton of research, but I'm happy to go back to that if we have time. So what's on the horizon? So I wanted just to share with you a trial that hopefully will be coming to Ottawa. So this is our effort to try to understand fracture, how we can prevent fracture in the safest way we possibly can in your population. So this is the preferred study. This is our randomized controlled trial of denosumab, and it's a denosumab care pathway. And it's going to be for patients on maintenance in-center dialysis. It's going to be integrated into dialysis care, and it's ideally, I'm hoping, in a larger trial focused on fracture outcomes. And what our intervention is in-unit administration of denosumab, and then very early protocol-guided calcium and vitamin D prophylaxis, and very close calcium monitoring, as we know your patients are in the unit being seen very frequently. And this table, I won't go through it in detail, but just to show you that, and this is the FREEDOM trial of denosumab, so our very traditional randomized trial, and just to show you that our trial, we're doing the best we can to mimic what we would do in our own clinical practice, so what we would do in our osteoporosis clinics, rather than trying to do anything too technical that involves too much follow-up for our patients. So we're trying to keep it as pragmatic as possible. And we're doing this very much centrally. So we have central consent for patients. They're connected to our research assistant remotely, providing consent in that fashion, going through all the risks and benefits of drug. And then we're following our efficacy data for our larger trial using ICS databases. And so we'll save us having to go and do lots of follow-up. Now we are, of course, doing a pilot study, and this one will hopefully again come to Ottawa. We've got some paperwork in place here, but what we need to do is obviously pilot this, and we need to show that we can streamline consent, we can have good adherence to our protocol, and we can confirm that patients are adherent to treatment assignment. And of course, harm, we want to make sure we're avoiding harm. So we're taking some extra steps to make sure that we're monitoring our calciums very, very closely. Our study is guided by a very astute DSMB, and we're doing it as safely as we possibly can. And again, with our secondary outcomes, probably less so for the pilot study, but looking at serum calcium, fragility fracture, and then also because this trial is a bit outside of the box, looking at participant satisfaction with our methods. And you can see some of the trials. We've got 3 up and running here in London, and we'll get some of our satellites, and then we'll hopefully be onboarding some of our academic sites early next year for the pilot. I'll just highlight that there is a trial of vitamin D that will be published at some point, vitamin D and mortality, which is run pragmatically, very interestingly. And then just a couple of other trials here. So there's not a ton, unfortunately, in bone health, but some interesting stuff coming up from even some of our co-collaborators and investigators. So stay tuned. So take home here, and then some time for questions again. So why are patients at CKD at high risk of fracture? Well, again, multifold, dialysis, you've got to watch these folks, and those who tell you they've had a fracture, or they've had lots of fractures. Those are the people we need to really zone in on. And then hopefully you've got a little bit of an approach to fracture prevention. So I'm optimizing CKD first, and then I'm going down the pathway of the kind of osteoporosis and what I can do to help treat that. Who I'm treating, again, it's patients at high risk that I feel are going to benefit more than be harmed by my treatments. And you can see some of the guidelines are changing slightly in terms of maybe relying on some investigations a little bit more to help with that decision making. Teriparatide, there's some evidence in adynamic bone disease. So I have done this in some cases. It is difficult to get access to, but it's expensive, but it is out there. And then otherwise it really is denosumab. And then some clinical trials coming up the pipe. So I'm all finished. Thanks so much for your attention, and I'm certainly happy to take any questions that you might have.
I'm sure there will be many. Thanks, Kristin. So if anyone has any questions, raise your hand or unmute yourself and go ahead.
Hi, Kristin. It's Deb Zimmerman. I have a few questions for you.
Sure.
Recognizing the lack of data. Given the concern about atypical femoral fractures and folks who have been on long-term bisphosphonates, and we don't really know, what happens in CKD as the bisphosphonates, potentially come out of bone. Has there been any evidence, or has anybody looked at whether or not these atypical fractures might actually be elevated in the CKD population?
I have not, and I've looked specifically. I've not seen any mention of the adynamic bone disease or that kidney disease as an increased risk, but I suspect it probably is because of all the other. Sorry about this. Because of your other comorbidities in CKD, but I would love to see that.
I just have two more. I don't want to monopolize. So when you look at the randomized control trials in the general population, how long before the curves actually separate where you see an actual protective or a reduction in fracture in the treated compared to the placebo group? Obviously, again, I'm mostly a dialyzer. So, the life expectancy of our patient population is so short.
Yes.
And clearly, in order for the treatment to have value, they need to live long enough to get benefit.
Yes, that's an excellent point, and it's kind of the same perspective we have with our long-term care population. I think in the geriatric guidelines is if the patient's not going to live for more than a year, it's probably not worth, unfortunately. But what we tend to see is that fracture prevention bone density benefit is at about a year. Where we start to see things diverge. So for instance, if I've got someone on drug and they fracture, within 2 months after, I don't call that a failure. I wait. I like at least a year to show that drug is going to help that patient.
On that same note, there's obviously been a shift away from estrogen in postmenopausal women, but I truly wonder, and again, I haven't seen any data about this in the ESKD population where the breast cancer concerns maybe aren't the same. Some cardiovascular stuff, whether or not estrogens, drugs like raloxifene, whether or not they might actually have a role different from the general population.
Yeah, so raloxifene and estrogen, some of our bone specialists do preferentially use those, particularly in patients where you're thinking that they may have some adynamic bone disease because it's not an anti-resorptive. So I have in fact used raloxifene on one occasion. The only trouble with raloxifene is it just doesn't work well in general. It only really works well at the spine. So I'd say for your patients, if they've got really terrible hip disease or they've had hip fracture, I think probably raloxifene might cause more harm than good just because of the risk of potential blood clots. With respect to the traditional HRT, it probably works better than raloxifene. I've not used it yet, but I think it's a great question, and certainly some of our practitioners do go to it as an option.
Thank you. So there are a few other people also who have questions. So maybe Todd first, and then Chris.
Thanks. That was really enjoyable. And for somebody who shies away from looking at metabolic bone disease because I don't understand it, this has given me a bit of insight. Maybe two kind of questions about your own clinical practice. I seem to have a population of patients that are mildly hypercalcemic, but also have low measured vitamin D. Usually I'm not measuring the vitamin D, but it comes from the family doctor. Are you supplementing with vitamin D in that situation despite mild hypercalcemia? That would be my first question.
Yep, so great question. I tend to, just because, so I get the same, and it's usually a question like, could they have secondary hyperparathyroidism? Is it something beyond the kidneys? I do very judicious doses. So the most I tend to do is like 1,000. And I see what happens with the calcium. If the calcium doesn't budge, I feel okay with continuing and just knowing it's going to take me a long time to replete them. So I tend to. I wouldn't do 4,000 or anything like that because I think you're going to get into trouble with much worsening hypercalcemia.
Perfect. And I guess my second question is maybe a little bit like Dr. Zimmerman's question. So we do have this fairly large population of what I would call palliative dialysis patients where their life expectancy is maybe under 2 years or under, and yet they're probably also our most frail patients with the highest fracture risk. Again, looking at kind of safety data for things like bisphosphonates, if we were to use over that type of time period, a year or two, are we looking at potential side effects from these medications, or are we actually, hopefully helping these patients have that fracture, which ultimately is going to lead to their early death?
Yeah. I think if you have your really time-limited patients who are less than a year and are sick, it honestly, you can talk with the families, of course, but it may be more work and potentially more harm than potentially good. But if you have somebody who you think, is got a couple of years and would just be so terribly affected by a fracture, it would land in hospital or they would land in long-term care or even die earlier, then I still think that there is some utility in having the conversation. Now, you asked about bisphosphonates, and I have in some people who've had terrible hypocalcemia for a number of reasons on Prolia. I have, in fact, off-label used bisphosphonates in those patients who I'm really worried that they're going to get into trouble if I give them denosumab. And what I've done is I've used a half dose of bisphosphonates. It's been okay. I mean, it's not the best, but you feel like maybe you're doing something. And again, that's not evidence-based at all, but may help if you're kind of stuck between what to do for that person that's going to live between 1 and 2 years.
Thank you. Chris.
Hi, thanks for that. I'm an endocrinologist too. So when I saw from Swap's Twitter account that you were giving a talk, I said I'm going to join in. So thanks for the talk. I do a lot of osteoporosis here too. So it's good to hear a lot of what you're doing is what I'm doing too. So if both of us are doing the same thing, it must be great, right? So my question for you was just, it's great how you're doing a lot of DMAB in CKD. Some like big, those big talks at ASBMR, some of them say, oh, never do DMAB in CKD because of adenamic bone disease. So I'm really happy that you're looking into that because, you can't prevent all the cases. My question to you is, the whole thing about the rebound vertebral fractures, is that well understood in CKD? If you stop Prolia for whatever reason, what's your preferred thing in CKD? Is it raloxifene? Is it every other day Residronate or every other week, which is also what I do. How about, love to hear your thoughts.
Yeah. I have had terrible luck with lots of bone density loss coming off DMAB unless I go to like IV zoledronic acid. So in my practice, I actually haven't had one transition off, but I would probably go bisphosphonates for sure. I would ask the nephrologist and I would say, what do you think about an IV? Because I suspect I'm probably going to do the best with it if they're on dialysis. If they're not on dialysis, I probably would do the oral bisphosphonate and see if I can get them off that way. But yeah, it's a big issue. I don't have any data to suggest that the CKD patients are at higher risk of rebound fracture coming off of denosumab, unfortunately, but I suspect they are, just given their, the way that they are and their comorbidities and things. Can I ask you if you do your 25D as well on these folks?
Yeah, I sort of, it's one of those things, as you could have said, like you kind of feel like you have to do something, and something in this case is likely better than nothing at all. So I just kind of say, yeah, it looks like you're already on calcitriol by, Dr. Hesketh, Dr. McCormick, but we're going to throw in the extra vitamin D2, sorry, D3 as well, not just D2. And it's also in the hypopara literature too, like, so think outside CKD for a bit, where, yeah, when you treat people with calcium activated vitamin D, you're still giving them regular, garden variety vitamin D. Maybe it's because of the other tissues have vitamin D receptors.
Right. Yes, right. Thank you. Thanks for your perspective.
I know it's 9 o'clock, but Peter raised his hand, so I'll let him jump on the vitamin D.
Years ago, an osteoporosis expert told me that there are other metabolites of vitamin D and we shouldn't focus just on 125. Is that still thought to be the case, or is 125 the only metabolite that matters? Because that was an argument for using D3, which I guess I did for ages until Swapnil told me it was a complete waste of time and just added to pill burden for patients. So maybe I haven't in the last couple of years.
Yeah, I know there is controversy. I think both are valuable personally. I honestly think it's a bit of an endocrinology nephrology thing, where our practices differ a little bit. But yeah, I don't think it's an all or nothing 1-alpha. There's vitamin D conversion in other tissues beyond the kidney. So my practice is to do both in the right patient if there's not significant hyperphosphatemia. So I'm kind of with probably the way that maybe you had learned prior.
Yeah, let's see if Peter changes back and then he'll blame me for convincing him of the nihilism. Anyway, thank you again. That was wonderful. Thanks for the presentation. This video has been recorded and will be available for later viewing. And I'll let people know when it's available. Thanks again, Kristin, and we really look forward to